A cataract in children and young adults can be from many, many different things. Can be from trauma, inflammation, different drugs, metabolic disturbances, gene mutations that affect the lens only or the eye only, such as in the crystalline genes, or mutations that cause syndromes or systemic disease. When we talk about lens opacity and cataract, people tend to just say cataract, but actually there's a lot of phenotyping that goes into cataract as well. And the phenotype of the cataract can help guide what the underlying diagnosis is when we have a child with a pediatric cataract. The opacity can be under the anterior capsule, the posterior capsule. It can be in the nucleus. There can be an anterior bowing of the lens capsule, a posterior bowing, or there could be opacity in the Y sutures. All of these different phenotypic features should be noted by the ophthalmologist because it can make a difference in understanding what's going on. Also important is phenotyping a part of the eye that's often not discussed as much as it should be. That's the gel behind the lens, the vitreous, and the appearance of the vitreous and the findings of the vitreous can also be very helpful in giving a clue as to what is going on in a child with cataract. Now, when pediatric cataract occurs in the setting of a syndrome or systemic disease, the fact that there is a syndrome or systemic disease is typically obvious. For example, here's a child with complete white cataract, and he's got hypotonia, flat face, thin, sparse hair, almond-shaped, downslanting palpebral fissures, congenital heart defect. Of course, this child, has one of the most common syndromes that we see, Down syndrome. Now, most children with Down syndrome don't have pediatric cataract, but for sure the incidence of pediatric cataract is higher in Down syndrome than it is in the general population. Here's another child who's obviously syndromic and comes in with cataract. He's got microcephaly, large ears, he's got a particular facies, and this child happens to have the microsyndrome or Warburg microsyndrome. And actually, the cataracts in these children are quite distinct. They're congenital membranous cataracts, and the pupils poorly dilate. Another example of a syndrome, a child who has cataract in the setting of syndrome, and it's obvious the child has a syndrome. There are many, many different syndromes that are associated with pediatric cataract. And here's a partial list of some of them. This is not meant to be read. This is just to highlight how many there are out there. And again, most of the time when a child comes in with a cataract that's related to syndrome or systemic disease, the fact that there's a syndrome or systemic disease is typically obvious, even if the diagnosis hasn't been made yet. This is not what I'm concentrating on my talk. What I would like to highlight to you are some examples of where pediatric cataract occurs as the sign of syndrome or systemic disease, but that syndrome or systemic disease has not been suspected or diagnosed. And let's start with the first scenario. The first scenario is represented by this 12-year-old girl referred with right intraocular lens implant. She had had cataract surgery in her right eye when she was 6 years old, and she's referred for follow-up. No other diagnosis for this patient. She has an artificial lens in her right eye. The left eye is clear, and she has mild myopia in the left eye. And here is a slit lamp picture of her left eye with the clear lens. And I don't know if you can see this, but take my word for it if you can't. Behind the lens, as an ophthalmologist, we can examine the vitreous, and the vitreous is not normal in this patient. The vitreous has what's known as a beaded appearance, and this immediately raises some red flags and prompts a specific question to be asked. And that specific question is whether or not there's any hearing difficulties. And sure enough, the child is hard of hearing. When we do a pedigree, we find out that the mother had poor hearing, she had retinal detachment, and has had knee surgery for pain in the knees. Her brother has poor hearing also, and also had spontaneous retinal detachment. This pedigree is screaming at us, of course, Stickler syndrome. And this is what this child had, Stickler syndrome. Stickler syndrome, of course, is part of a spectrum of collagenopathy that ranges from Stickler syndrome to nice dysplasia. We all know about Stickler syndrome, and they're known characteristically for their facial features, their hearing loss, arthropathy, and predisposition to retinal detachment. But it's important to know that juvenile cataract can also occur, and these patients can present as juvenile cataract. The vitreoretinopathy can lead to juvenile cataract even in the absence of myopia or retinal detachment. Worldwide, most cases are from collagen 2A1 mutations, but the genetics are a little bit different in the Gulf. And any child who comes in with high myopia should be considered a Stickler syndrome suspect. This vitreous phenotype really makes the diagnosis. And this is the power, something that ophthalmologists who are experienced in this have, where looking at the vitreous can specifically be pathognomonic for having Stickler syndrome. Again, here's a normal picture of a vitreous just to show you, and some examples of how the vitreous can be abnormal in Stickler syndrome shown underneath it. Cataract in Stickler syndrome is typically a segmental cataract, lens opacity, but different things can occur. They can get posterior subcapsular cataract also, as the girl I just showed you. Here's an 8-year-old boy who comes in with high myopia and posterior subcapsular cataract. He's just referred for cataract and high myopia. No other diagnosis has been made. And he's got that classic vitreous finding when we examine him at the slit lamp. Take a step back, and he's got a flat face as well. He's got retinopathy. He has undiagnosed Stickler syndrome. Stickler syndrome is easy to suspect when you have a child with high myopia, flat face, and hearing loss, but it's not always that clear cut. Again, the vitreous really gives us indication of we're dealing with Stickler syndrome. It's pathognomonic. It's a secret weapon of ophthalmologists who are experienced in this. Another child, again, who had cataract surgery. He wasn't diagnosed with any other thing, but looking at him, he's hard of hearing. He's got a very flat face. He's got a bifid uvula. He's got joint problems. He's got a very severe collagenopathy. He actually had a nice dysplasia, undiagnosed until this time. So the first sign I've gone through now, pediatric cataract as a sign of undiagnosed syndrome systemic disease, Stickler syndrome spectrum, and related vitreoretinopathies. Here's another scenario. This is a child who comes in with congenital cataract. When we have children with congenital cataract, many different causes, but we really have to be concerned when the child is floppy. Then we have to worry about systemic diseases. One systemic disease that comes to mind in a boy who has congenital cataract is Lowe syndrome, X-linked Lowe syndrome, which is associated with nephropathy. It's an important diagnosis to make. There's genetic testing available, but if we suspect the diagnosis, we can often make it clinically with the help of someone in the room, and that's the mother. Lowe syndrome is X-linked, and when we look at the mothers of these patients, it's typically inherited. We see these radial lens opacities, which is the carrier sign of Lowe syndrome. Here we just made a genetic diagnosis in this baby with congenital cataract based on this phenotyping without doing any genetic testing. The female carrier signs in Lowe syndrome are very interesting. Of course, Lowe syndrome patients have a dysmorphology that's recurrent, but looking at the lens of the mothers of the carriers can be very helpful in making this diagnosis. It's interesting, there's another form of X-linked cataract, syndromic form, known as Nance-Horan syndrome, and these patients have a different dysmorphology than Lowe syndrome patients in terms of their facial features, but so fascinating, the carrier signs are different. In the Lowe syndrome carriers, the mothers, the females, or the sisters have this radial lens opacity. They're asymptomatic, of course, because it doesn't affect the vision. Whereas in Nance-Horan syndrome, the female carriers have lens opacities on the Y sutures. It's amazing how distinctive this is and how specific it is and how useful it is in making a clinical diagnosis in these patients. Here's a patient who was consulted for blurry vision. He's a male in his 20s awaiting renal transplant from the mother. Ophthalmologist is called. Why does this patient have blurry vision? When we examine him, he's got anterior lenticonus. The lens is bulging. Why am I showing you this case here? Well, this patient has anterior lenticonus. He's waiting a renal transplant. He's got renal insufficiency. He actually has Alport syndrome, and Alport syndrome is often X-linked. This is probably the only time in the history of renal transplantation that an ophthalmologist canceled a renal transplant. Had it been from the mother, who's a carrier, it would have likely failed. And this was all confirmed genetically. Here's the anterior lenticonus here, bulging. Again, the power of ophthalmic phenotyping in helping to make a diagnosis that had not been made previously. The final scenario I'd like to share with you is represented by this child. She's a 14-year-old with recent decreased vision. Her older sister also had cataracts and had cataract surgery. Now, the lens opacities in this child are different. You see these flecks in the lens? When you see flecks like this that are acquired, you or we as ophthalmologists need to consider the possibility of metabolic disease. It's not these flecks that are decreasing the vision. There's also a posterior subcapsular cataract there that's not highlighted. But this is all worrisome for a metabolic disease. And in fact, this patient, when we investigated her, had undiagnosed cerebrotendinous xanthomatosis. When we made this diagnosis genetically, I went back and asked the mother, did she have intractable diarrhea as an infant? And the mother said, yes. How did you know? She never told me that before, but I never asked her the question. Two of the hallmarks of cerebrotendinous xanthomatosis are juvenile cataract and infantile diarrhea that's intractable. There was a younger brother who was actually asymptomatic visually, who we picked up with genetic screening. And here you can see the fleck-like opacities accumulating. They haven't, cataract hasn't come to a stage where it's visually significant, but he also had infantile diarrhea, and he also had this condition. This is probably the earliest diagnosis made. This is a pre-symptomatic diagnosis, pre-visual symptoms diagnosis. Cerebrotendinous xanthomatosis is an extremely important disease to know about for ophthalmologists because it's treatable. It's a progressive storage disease where cholesterol deposits accumulate throughout the body. And by intervening with chenoxydecolic acid, the metabolic pathway can be normalized and degeneration can be prevented. So it's really, really important that we pick up these patients. We ophthalmologists are in a unique position because we see these patients with juvenile cataract, but unfortunately, the diagnosis is often not suspected. It's very underdiagnosed. And if it's ever made, it's often made 10, 20 years later after the degeneration has occurred. Here's the metabolic pathway. And again, this cholesterol and the 25-hydroxylated bile alcohol accumulate because of the lack of the enzyme, giving the cholic acid stops the accumulation of this pathway. And if you look in the literature, you can see the different cases. They all are very similar with this fleck-like opacity in the lenses. Here are other cases. Again, phenotyping is key. It's really, really important. You know, it's incredible that when a prospective study was done of children with juvenile onset, quote unquote, idiopathic bilateral cataracts, an incredible 2% of them had cerebrotendinous xanthomatosis. That is a very high number. This diagnosis needs to be on the radar of pediatric ophthalmologists and geneticists as well. I'm happy to say it is much more prominent now and is in the curriculum of ophthalmology teaching. One of the reasons this is often not diagnosed is because it presents to so many different specialties at different times of different ages, and it's unfortunately that people don't tend to put it together. So that brings me to the end of what I wanted to cover. Pediatric cataract is often, when it occurs in the setting of a syndrome or systemic disease, the fact that there's a syndrome or systemic disease is typically obvious. However, I've gone over situations where pediatric cataract is a sign of undiagnosed syndrome or systemic disease. And I hope I've given you a flavor of how powerful ophthalmic phenotyping can be and useful in making these diagnoses. Thanks for listening and thanks for including me.